Hi, today we're going to talk about pathophysiology plaque psoriasis case study. Case study for psoriasis. Patient KB, a 40-year-old white female with a 5-year history of limited plaque psoriasis. At the age of 14, KB suffered a chronic episode of rheumatoid fever with complications of rheumatoid heart disease. She initially responded well to topical treatment of high-potency corticosteroids. KB does not have a first-degree relative with psoriasis, no family history or immune disease of psoriasis. Her mother recently passed away of ovarian cancer and her father is alive and well. KB has siblings, 3 sisters and 2 brothers. Her youngest sister, who recently developed heart disease due to rheumatoid fever many years ago. KB scheduled an appointment with her dermatologist and presented with her third relapse flare-up since her 5-year diagnosis. KB has been in remission for 18 months. KB is married with 1 son. She works as a purchasing agent for the last 13 years. Her social history: she smokes 45 cigarettes a day. She drinks alcohol socially. She is stressed at home due to family bitter words between her father and siblings. KB is also experiencing increased anxiety, tension at work due to rumors of downsizing and layoffs. What is psoriasis? Psoriasis is a common relapse chronic inflammatory disease of the skin, and it is characterized by loose, adherent, silver-white scales covered bright red with a well-rounded plaque, and plaques are lesions that are elevated and rough. The disease can present in many forms. Onset age is widely variable from infancy to old age. The median onset age is 28 years old. It occurs in all racial groups, but it is also common in Caucasians, especially the Western European and Scandinavian heritage. Plaque psoriasis. It is a lifelong condition that causes thick, scaly red skin, and it affects about 7.5 million adults in America. Plaque psoriasis is the most form of psoriasis. It is caused by an overactive immune system. There is no cure, but there are several treatment options that may help to control the outbreak. It is also known that the immune system, the environmental factors such as trauma, stress, chronic infections, low humidity, cold weather, smoking, obesity, and drugs such as beta blockers and lithium. Family history plays a role. The immune system speeds up, which causes inflammation and a large number of skin cells to grow instead of falling off. So they just build up, they pile up on the surface of the skin, forming the psoriasis plaque. Psoriasis plaque appears as raised red patches covered with a silvery white buildup of dead skin cells or scales. Most often appears on the scalp, the knees, the elbow, and the back. So the presumptive factors you would, was identified as on the physical exam as KB complaining of itching, mild anxiety. She had abnormal labs, and on her abnormal lab she had low calcium of 6.9, a hemoglobin of 11, a hematocrit of 32%, RBCs, red blood cells, was 4. All of these was slightly low, but the cholesterol was 289, which was high. And in her physical exam, we also found that the skin had merging plaque type psoriasis that was extensive lesions on her upper and lower extremities, her scalp, her abdomen, and the groin, covering approximately 40% of her total body surface. The lesions are bright red in color with sharp defined borders, except where they're merging, and are covered with loose silvery white scales. There was no pustules, no vessels present. The lesions on her arms, legs, abdomen consisted of scales, excoriation. Extensive scaly lesions was on the scalp, and extensive scaly lesions and excoriation was on the abdomen. Psoriatic lesions on the elbow and the knees, forearms, and calves. Yellow spots in the nail plate of her fingers. There is the heart murmur was heard, and that was from the rheumatoid heart disease. Her blood pressure was elevated. It was 145/90, and she is overweight according to her height. Pathophysiology. Pathophysiology of psoriasis. Pathogenesis of the psoriasis is unknown. It's an autoimmune mechanism in which the T lymphocytes respond to an unidentified antigen in the skin is suspected, and it's activated T cell helpers, and these T cells help to activate the cytotoxic T cells and the macrophage to attack infected cells, or they stimulate the B cells to secrete antigens. So it's almost like they're releasing white blood cells to attack the antibodies. There's synthesized and released chemical meteors of inflammation that attacks the neutrophils. It stimulates on the epidermal cells to divide, causing vasodilation. The angiogenesis is of the capillaries in the dermis, And this type of process is where new blood cells develop. There is a rapid proliferation of cells, does not allow time for the cells differentiation, which is the maturation, which is the maturing to occur, resulting in thickening epidermis with plaque formation. A thin layer of keratin gives the lesion a shiny appearance. So basically what it's saying is on psoriasis involves the dermis and epidermis layers of the skin. So the duration of the cell cycle, the cells divide at a rate 7 times of a normal epidermal cell. Decrease in migration time for cells through the epidermis. The shedding of the epidermal tissue is decreased from the normal 26 to 30 days to 3 to 4 days. And so with the pathophysiology of psoriasis over time, everyone experiences different symptoms of plaque psoriasis in different ways, which may vary based on the type of psoriasis as well as the severity. So some of the common symptoms that you will see would start out with redness, a low elevated area of inflamed skin, a scaly silver colored patch in the inflamed areas. You have cracked skin, dry skin that may cause bleeding, is sore, is itchy, or burning skin. And itching is a common symptom of many dermatological and systemic diseases. Although very common, itch is very hard to describe. Itching is a sensation that, if significantly strong, will provoke either conscious or reflex scratching or the desire to scratch. It consists of multi-dimensional phenomena with sensory, discriminative, cognitive, evaluative, and motivational components. Itch has similarities with pain, but in contrast to pain, itch decreases the scratch cycle, which combines with the element of the pleasure with the pain. So in looking at KB's underlying symptoms, we look at the percentage of her body weight, which was, the percentage of her body surface affected by the psoriasis was 40%. And when you look at the scale, 40% would be moderate. So she has moderate plaque psoriasis at this time, which that's what we'll be looking at, how we look at treating her. And I would be saying that her anxiety, the stress, the tension, the smoking, all is in her high blood pressure is all causing her flare up of the plaque psoriasis. And in treating and when you look at treating the psoriasis, we have to look at the type of psoriasis. We look at the type of medication. When we look at the types of medications, we'll look at, since she has the lesions all over her, then we will look at treating her topically, which is suitable mainly for every patient. And then we have to look at how potent it needs to be in order to give her some relief from the itching. And that would be in the form of creams, ointments, and we'll also look at the systemic part of it all because it is internal. So we want to treat her with something that's oral form, which treats the systemic psoriasis, the internal part of it, so that we could cover both the internal and the external because of the 40% body surface. In my the company that I work for, they usually start out with prednisone as the oral, and what they do is they give her large doses, and then we started to decrease it and eventually taper her off. So with the oral medications and also with the topical, you will see that when you're using those type of medications, studies have shown that people with severe psoriasis treated with methotrexate typically begin to have a reduction in symptoms after 6 to 8 weeks of treatment. After 5 to 6 months of treatment, with the slow increasing dose of methotrexate, between 50 to 70% of the patients experience reduction in symptoms. 75% or more. And symptoms reduction is frequently measured. And methotrexate works by affecting the way a person's immune system controls the inflammation in the body. A person with psoriasis has an immune system that is overactive and produces too much inflammation. This inflammation triggers the production of an excessive amount of new skin cells, which cause old skin cells to build up on the surface of the skin as plaque. Methotrexate helps to prevent the production of new skin cells and can also help to reduce inflammation by targeting the T cells that trigger the inflammatory process. And with the corticosteroid therapy, the topical corticosteroids remain as one of the most widely used treatment modalities for psoriasis. Corticosteroids have anti-inflammatory, immunosuppressive, and anti-proliferative properties. They bind to a receptor in the cytoplasm of the cell and are transported to the nucleus, where they affect gene transcription. The efficiency of an individual topical corticosteroid is related to its potency and the ability to be absorbed into the skin. Absorption can be enhanced by the use of plastic occlusions or by the type of corticosteroid chosen. And for the treatment options for plaque psoriasis, learning about the different options can help you partner with your doctor, help the patient to partner with the doctor to find out the right treatment. And for the right treatment, like I have mentioned earlier, the topical treatments, triamcinolone Ointments, you could be in the form of foam or gels, can be applied directly to the plaques. There is phototherapy, which is a form of light therapy, which ultraviolet rays shines directly onto the plaque. So in that in the phototherapy, when you look at it, when a patient gets that treatment, they put like a type of cream on there, and then they have them to stay up under the ray of the light for a certain amount of time. And for the systemic medications, and those are the ones that's taken orally by injection, they work from the inside of the body, not just on the skin. And the biological medications generally taken by injections, they target certain parts of the immune system. So to summarize the treatment for KB, the flare-up was caused probably by the environmental factors, which was if she would watch her diet, if she would, if by her watching her diet, it would also help her blood cells to rejuvenate. And when you look at her stop smoking, that would help with her blood vessels. So with her treatment, the corticosteroids, since the last prescription worked well, that could be reordered. Then you could put her on the prednisone or the methotrexate for the systemic medication. She should also be on birth control, use a condom, because to prevent her from getting pregnant. And then you want to monitor her liver and her kidney functions, also her CBC labs. You want to help her to monitor her blood pressure at home. She needs to stop smoking and drinking. And then watching her diet, it will help her lose some weight. She needs to reduce her stress, her anxiety, and tension within her work and home environment. By doing that, she could take a walk, 15-20 minute walk, to help her to relax and get out of the environment to reduce the stress level. And it could take 6 to 8 weeks for us to see any difference in the medication working at this time. The medications will be readjusted as needed. Possibly if it's improving, you would decrease the amount of medication, eventually weaning her off of it. Multivitamins is another good thing because that would also level out her blood levels, and also folic acid, and that would calm the symptoms of the nausea and the vomiting that the methotrexate might give her as a side effect. Thank you.